Next, I call upon Dr. Mallika Goyal ma'am to take us through the treatment options for macular edema following vein occlusions.
And I would just like to ask one brief last question, Dr. Agninder. If you have a massive submacular bleed, just briefly, how would you approach?
First thing, I'll look at the vision. If the vision is good, then I'll go for anti-VEGF treatment. If the vision is low and the bleed is submacular, then my first choice will be give a C3F8. Depending, I can combine with TPA, with C3F8, with anti-VEGF. So after giving C3F8 and TPA, usually the blood, the idea is to displace the blood from the subfoveal area, and once this blood displaces, there is a vision improvement. But the final treatment will be anti-VEGF.
If the patient comes early enough, say within 2 days, you may not need TPA even, just anti-VEGF and gas would be enough. If it's more than 2-3 days, you feel the blood would have clotted, then you can add a TPA. Okay. So I'll speak on retinal vein occlusions, mainly my experience. So the first important thing, of course, is to look for comorbidities and identify and treat, which are the most common listed here. The ocular morbidity, very common, is glaucoma, so look carefully for it, we can miss it. And the importance of identifying coexisting glaucoma is the treatment also changes. If it's a glaucomatous eye, you will avoid steroids for macular edema. And for glaucoma management in these patients, you will try to avoid the drops which cause macular edema, such as prostaglandin analogs or alpha agonists. You will probably switch to beta blockers. Now, classification of retinal vein occlusions depends on the site of occlusion, whether it's a central retinal vein, hemiretinal, or BRVO. And central and hemiretinal vein occlusions could be ischemic or non-ischemic. And the treatment also, the treatment and more importantly, the prognosis depends on whether it is ischemic or non-ischemic. And in branch vein occlusions, it could be a major or a macular vein. When you're dealing with an ischemic CRVO or HRVO, the macular edema will be very severe. The vision is very poor at presentation, usually hand movements or counting fingers at 2 meters. And the prognosis is poor. We can tell the patient that even with injection, the edema will go, but vision will not improve because of ischemia. And they are the ones who are likely to come back with repeated edema and recurrent injections required over several years. So this is a patient, an example. Sometimes, on the other hand, you may not have much edema, but the vision is disproportionately poor in these ischemic cases. And despite injections, they may go into macular ischemia. No edema, but very poor vision because of ischemia. So prognosis remains poor, and in these patients, while we are treating the edema, we need to be vigilant for new vessels on the iris and neovascular glaucoma. On the other hand, in non-ischemic CRVO, the edema is mild, vision is 6/9, 6/18 at presentation and improves rapidly, and they may require very few injections, may not come back with many recurrences. Treatment of HRVO macular edema is really not well defined. You could treat it as CRVO, where you don't do laser, or you could treat it as BRVO, where you can add laser after anti-VEGFs, because there are no studies to guide us on HRVO macular edema. Macular branch vein occlusions, they are little straightforward in that we don't expect neovascularization because the area of involvement is very small. So we don't expect proliferative retinopathy. So as I mentioned, in RVO, what is very different from DME, diabetic macular edema, is constantly to look for the new vessels on the iris at every visit in every patient of HRVO and CRVO. Not to miss that, especially when the macular edema is gone and we have stopped giving anti-VEGF frequently. That is when the new vessels on the iris will start coming in. And we have to pick it up for early laser. And in BRVO, we have to keep looking for new vessels in the periphery or on the new vessels on the disc, because again, these demands laser at the same time. So not to miss these serious problems while we are treating the macular edema. Investigations, photography is very important. It captures things which OCT cannot capture, such as hard exudates, which will not be captured accurately by OCT. Hard exudates are extremely important. They can cause permanent damage. So we have to prevent these coming into the fovea rather than rush after them when they've already involved the fovea, because they will leave behind some damage permanently. So this is to show a patient who has come with inferotemporal BRVO, which is not visible now because she has been getting anti-VEGFs. But if you do an angiogram, you can see it's an inferotemporal BRVO causing exudates. So we gave her an injection, and you see within 5 to 6 weeks, the exudates have started resolving. And now we did laser for the patient. This is another patient. We gave an injection, but despite that, at 4 weeks, the exudates are remaining the same. Of course, exudates take more time. They take a few months to resolve. But we have to prevent involvement. Now, this patient is 6/6. There's no edema. But why we are treating him is to prevent this exudate from entering right into the foveal center, which is when he will lose vision and not recover easily. This is another patient we did not treat. So you can see within a few days, within the same month, his hard exudate has moved into the foveal center. You can see the left and the right pictures. So this is how important it is to treat foveal exudates in a preventive manner. Here it is to show that edema and exudates behave in different manner. We injected, and at 4 months later, the edema is little less, but exudates are increasing because the gap is too much. When you see exudates, the treatment has to be a little more aggressive, every 2 months rather than 4 to 6 months, because that allows the exudates to increase despite treatment. Now, photograph can capture the loss of hard exudates over time, over 4 years, which OCT is not capturing, as you see. So you can show the patient that because of treatment, your exudates have gone, though edema is still persisting and vision has not changed. Fluorescein angiogram is very important to show how to treat the edema with laser, because it captures the leakage, which OCT angiogram cannot show where is the leakage. Now, these are the multiple studies related to management of retinal vein occlusion, which everybody can see. So the first line of treatment in retinal vein occlusions remains anti-VEGFs, not steroids, because steroids have too many complications. And these are the more recent studies which have shown that aflibercept of the available anti-VEGFs has a much better visual and anatomic result compared to bevacizumab and compared even to ranibizumab. Significantly fewer injections are required with a greater proportion of patients which have a thinner macula, better vision. And those that are not responding to ranibizumab or require injections every 4 to 5 weeks, if they are switched to aflibercept, the treatment-free interval shifts to 9 weeks from 5 weeks. So it doubles. So it reduces the treatment burden with additional improvement in vision and reduction in central retinal thickness. So then what are the indications for steroids? Does it have any role? It is indicated when steroids are when anti-VEGFs are contraindicated. That is very simple. Anti-VEGFs are contraindicated when there is a recent history of cerebrovascular or coronary events, pregnancy, or severe nephropathy. Also, when we are finding some tractional retinal detachments already present and the patient has active new vessels, there if we give anti-VEGF, the TRD can worsen. So there you might want to use steroid for the edema component and do laser for the proliferative component. And of course, it is used when there is a suboptimal response to anti-VEGF injections, then steroid can be tried. Or when we are planning cataract surgery, it can be chosen over anti-VEGF because it can cover the anti-inflammatory, the inflammatory aspect as well. Steroids to be definitely avoided in patients with glaucoma, those who have prior history of ocular infections like CMV, or a large PC opening which can allow anterior migration of the DEX implant with corneal loss. Laser has a role only for macular, branch vein occlusions, where you have to do an fluorescein angiogram to know where is the leakage and then target that area with laser. Nowadays, laser is done only after the macula has been first dried out with anti-VEGFs, because then the laser energy required is less and it is more effective. So first anti-VEGF and then macular laser for BRVO. But we still do it only if we are sure that the edema is going to recur repeatedly if the patient is coming back. If the patient does not need more than 1 or 2 anti-VEGFs, then there is no benefit to adding laser, because laser also has risks. There is a long-term risk of foveal involvement with this scar enlargement, CNVM coming up later on, scotomas and other problems. So laser is also risky. should be added if the patient is repeatedly coming back with macular edema following BRVO. In CRVO, there is no value for laser, and if the vision is disproportionately poor compared to the edema, it could be because there is a cilioretinal artery occlusion, which is commonly associated with CRVO, as in this patient. You can see an area of infarct, the white area in the macula. And lastly, RVO in the young, it happens. Look for any drugs, oral contraceptives, sildenafil, and the prognosis is usually good. Just one anti-VEGF injection is usually enough. They don't come back with recurrences. But you have to investigate for collagen vascular diseases and rule out. It should be a diagnosis of exclusion that there is no problem. We had patients with post-COVID infection CRVO, and they usually respond to just steroids and anticoagulants. Occasionally, an anti-VEGF may be required. Post-vaccine, these are two young people, one coming with CRVO and BRAO in the same patient, and one coming with HRVO. The second patient required an anti-VEGF. The first, only steroid and anticoagulants were enough. Thank you.
Thank you very much, ma'am, for that excellent talk. I have a few questions for you. As far as some patients of CRVO sometimes present very early on in their course. They complain of visual disturbance. I've had a few patients who came with a 6/6 vision, but they also had a macular edema. So in those patients, would you initiate a treatment?
See, the fact that they have come to you is because they are symptomatic. So they are already symptomatic, even if they are 6/6. And if they have macular edema, you have to treat it, because I have seen that if they don't take the injection for whatever reason, then anyway it worsens. They come back after 2 weeks with a much worse edema. So for RVO, the standard protocol is to treat.
Yeah, because most of our study inclusion criteria is 6/9 or less vision. So
I think
they would not
see,
have,
the fact patient has come to you is that he is already symptomatic.
Yeah.
So then we don't look at the vision.
The take-home message is that if they
Yes.
have even a 6/6 vision and if they
Yes.
have macular edema or
You
a
have to
disc
treat.
edema,
Yes.
so better to treat those patients. And
if-
any experience of using Paginax as an initial treatment in these patients as of now, ma'am?
No, the risk is not worth it, because there is some risk with brolucizumab of inflammation. So why would I take that as first line? I might take it if there is a lesion which is not responding at all to aflibercept also. But otherwise, as a first line in any situation, why would you take the risk?
Any other take?
If you have a young patient with central retinal vein occlusion, so how will it differ from an elderly patient? Will you look at some other points into these patients?
Is your question young patient versus elderly?
Yeah.
Yeah, young patient, see, in a young patient, we already know the prognosis is going to be good, first of all. So our counseling is different. We investigate for a different set of diseases. Though we do look for diabetes, lipids, and blood pressure, we are actually looking more for leukemia or hyperviscosity syndrome, sarcoidosis, SLE, some of these diseases by doing a CBP and all. Most of the time, these will be negative. And in that case, we label it as idiopathic and we treat it with anti-VEGF if there is macular edema.
Is there any role of steroids in these?
Yeah,
young
earlier
patients?
when we didn't have anti-VEGF that much, we used to give only oral steroids. But the morbidity or side effects, even in young people, is not worth it, and we don't find the same result. So anti-VEGF gives an immediate result. So I think now there is no point in trying steroids, oral steroids.